All right, well, thank you guys for coming out. About this time last year, Nikki and I were at Medicine X 2013, and we really felt that there were a lot of conversations about the puzzle pieces that were missing between the patient side and the provider side, but there wasn't a lot of conversation with all of us on one panel. So this is where Bridging the Gap came from, where we've decided to come together and have a stakeholder from all different walks of life, and hopefully discuss some of the issues that we find come into our exam rooms and come into our private practices and come into our medical education that kind of keep us separated. And our goal today is to come up with some concrete action-based techniques that will hopefully help you in your own personal life as a patient, as a caregiver, as a physician, whatever your role may be. And we would also love to hear your feedback or your ideas and your challenges. If something you think that we've proposed doesn't work, we'd like you to challenge us, because that's the point of this, is to come up with some concrete ideas. So on that note, does everyone want to introduce themselves? Yeah? Okay.
Hi. Hello, hello, hello. Hi. All right, so we need font to be bigger, which is awesome, in case you want to say, quote things that I might mispronounce or misspeak on. That's fine. So as Emily said, we want to have something tangible to walk away with. Can you all see that? Is that cool? Anybody? Cool. All right. We want something tangible, so I think we're going to do like a loop around. We're going to start first with our perspective on the ominous 15-minute meeting with your doctors, because that's what everybody always defaults to. Obviously, your individual situation may vary. You might have more time, might have less time, whatever. We're going to stay with the 15 minutes, talk about some things, and then come back around to what can each of us do to improve that 15-minute meeting. And hopefully we will have happy things to report as a result of that. So we'll start at the end. Nikki, introduce yourself briefly and say something about your perspective on the 15-minute meeting with your doctors.
Okay. Hi, guys. I'm Nikki. Here is an e-patient diagnosed with juvenile rheumatoid arthritis in 2007. And so I started off seeing a juvenile or a pediatric rheumatologist. My perspective on the 15-minute meeting, I've had about 3 or 4 rheumatologists, and they varied very differently with each of them. So I've had meetings where it was just like, oh, how are you? Okay, cool. All right, here, take this. Goodbye. And then I had another where she was like, oh, how are you feeling? What's going on? What do you want to do today? What's the plan? So, I mean, that's kind of what I want to focus on, or with what I'm talking about, is the different experiences with the different doctors that I've had.
Hello all, my name is Rohit Kakade. I'm a second-year medical student at Oregon Health and Sciences University. I do a bunch of other stuff that's not really applicable right now, but my perspective on the 15-minute panel or appointment, it's tough. From a training perspective, and that's pretty much all I have right now, my clinical time is a little bit limited. There's a lot of things you have to juggle in those 15 minutes, and from a provider side, we want to do everything justice, and it's very hard to fit all of that in. So I'm looking forward to the solutions that we come up here.
So I'm Mark Katz. I'm a cardiac surgeon in Richmond, Virginia. My patient visits are not timed. I've never once looked at my watch or have a clock in the patient room. I mean, that said, there are people who are scheduled in a limited amount of time. But I've never felt that as a time constraint when speaking to a patient or dealing with that. So as a cardiac surgeon, it's a little different than a primary care physician where they're trying to see 30 patients in a day. So I may not be the best person to talk about with that, but again, I would never and have never, used a clock when I'm speaking to folks.
And I am Meredith Hurston. I'm one of the e-patient scholars for this year, and I'm actually a patient advocate. I was a caregiver for my mom. I'm not actually a chronic disease patient, but my opinion, I visit the doctor, I would say, annually, and I would say the 15-minute visit kind of like pigeonholes you, because before you go in, they ask you to write on a paper like, what is your chief complaint for the day? So you kind of feel targeted, like there's one thing that you can talk to the doctor about, but you might have actually 3 or 4. So that's what I want to get more into for the 15-minute visit.
Okay.
I think that's really interesting that you say that, because I've also heard from physicians and I've heard from med students that physicians don't have enough time to address more than one complaint. So it's very much, if you get into a primary care physician's office and you bombard them with 5, 10, 15 different issues, they're completely overwhelmed and they don't have necessarily the resources to address those. So I think this is part of why we're having this panel. Physicians have one perspective and we have another, and where do we meet in the middle to make it easier for each other? I have quite a few rare diseases, and that means I've seen specialists in many different fields, and I've definitely found a difference between specialties like rheumatology versus neurology versus surgery, depending on the situation. I've had visits that were 2 hours, and I've had visits where my rheumatologist would not turn around and look at me because the computer took up all her time. And I think that's something that we will touch on today as well, the tech aspect of things.
Your panel, whatever you want to do.
All right.
So as we move forward, I want to remind everybody that we're not trying to be accusatory one way or another. So, I mean, the 15-minute meeting potentially is the problem, not the doctors who have what they have to deal with. They have real lives too. They are human. Patients are human too. So we're not trying to point fingers. This is not about blame. This is about trying to build something better. All right, so let's try to start figuring some of this stuff out. The first thing I have written down here is how to effectively communicate with providers. What works for doctors? What's easiest for patients? So I guess from everybody's perspective, in the moments that you've found success, be it the 15-minute meeting, be it whatever your encounter has been with a healthcare professional, what have you found that works best from you from the patient perspective as far as conveying what you're feeling, conveying what you need, getting the most out of your meeting, most out of your appointment? And then from the provider side, what is the most effective means of communication for you? What's the information that's most pertinent to you? How is that information best conveyed to you? So there's a lot there, but the overall goal is to figure out how can we start to improve that communication process. We'll start on this side. Emily, go ahead.
I think that
It's a loaded question,
it's
I
a
know.
loaded question, and I think it changes depending on what you're trying to communicate. So I know, I think my pain has been communicated, and I think the swelling in my hands or whatever physical symptom that I can show them is generally communicated well. But I don't think the impact of those symptoms is necessarily communicated. I have had good experiences when computers and iPads were actually left out of the room because I find that they take up too much concentration. I just said it before, the having a physician's back turned to me completely, I will just shut down because I don't want to talk to your back. I don't want to talk to your back. I don't want to talk to your back. Like, it just doesn't work. I have found email to be highly effective when used the right way. And I think with email comes the issue of balance. How does the physician balance, having an open inbox policy? And how do we communicate to patients what's appropriate for email and what's not? But I have found that an effective tool with little things. So I think those are my suggestions.
By the way, there are a lot of us up here, but this is supposed to be an open discussion. So if you have questions, we have a mic to run around here in case you want to add something to it. Meredith?
I think I found success with just writing my questions down or how I'm feeling down, be it like in Evernote, like in an app like that, or just on pen and paper, and being able to just kind of read that off so that I get everything out that I wanted to say.
So coming as prepared as possible on your end helps the communication process.
Yes, and I think being able to thoroughly articulate how I'm feeling and not just say, hey, I'm not feeling too well. Like, be able to say, my stomach hurts here, be able to point to it, it feels this type of way. Go into detail so they can help diagnose you quicker, because just not feeling well, that doesn't give them a lot of information to go on.
Okay. And Mark, for the record, I think you are qualified to be on this panel. Don't worry about that. But for you, I mean, it's obviously you're the one who has to make these medical decisions. So what's been the most effective means of receiving information? From
Right.
your
So I
patients?
love it when patients come prepared with a page or two of questions, and I usually ask them to hold it until I'm finished with my, assessment and description of things, and it's usually my goal to have the questions answered before they can get the paper out. The other thing that we've been using recently is I was a beta tester for Flip the Clinic group, which is a group that's working on re-engineering the patient-doctor interaction sort of along the lines of the Khan Academy, and one of the things they developed that we've been using are these cards, and a series of cards that has a question or an emotion on one side, like I'm scared, I'm in pain. And then on the other side are a series of follow-up questions to help stimulate the patient so that they don't leave the office and say, oh, I wish I'd asked them A, B, C, D. And those have worked pretty well, and so started using those maybe 8 months ago as part of the beta testing for the Flip the Clinic folks, and I've continued to use those.
So we're going to keep going down the line, but really quick, this follow-up for you, Mark. What kind of, I have to ask, what kind of deliverables, what kind of measurables do you have to prove that this type of, communication actually works? I mean, it sounds great in my head. I'm sure a lot of the patients out in attendance, this sounds like a great idea, but when it comes to implementing this on a wider scale, what kind of data do you have to support that this
so
is a good thing?
I don't have any data on that. When we were doing it as part of the testing for the Flip the Clinic folks, there were some surveys, and I haven't seen the follow-up on that yet.
But you're, so you're unofficial, non-properly sanctioned opinion.
Good feedback from the patients, and that they like it, and that it has helped stimulate further follow-ups on their part.
Cool. Right?
So in med school, when we're taught about patient encounters, we're supposed to do something called agenda setting. You come in with a certain agenda, you want to cover certain things with the patient comes in with an agenda, and they want to cover certain things. The very beginning of that encounter, you should spend maybe 2 minutes or 3 minutes discussing what both of you want out of your 15 minutes together. So I think to Meredith's point earlier about writing down what you think is going on, the symptoms you're feeling, and just condensing into maybe like the top 3 things you want to get covered would be immensely useful for a lot of physicians when you go in to see them. And then to Emily's earlier point about email, interestingly enough, this summer I've been pursuing research on electronic health records and what physicians think when they use electronic health records. And one of the not biggest, but frequent complaints I saw was that physicians said the MyChart messages I receive are enormous. They are essays in and of themselves. And when physicians have 30 other patients to go see, they don't necessarily have time to do your email justice. So maybe figuring out a way of condensing those emails would also make that email process a lot more helpful for more patients.
What I've found the most effective with my rheumatologist is actually based off a recommendation of a doctor that I met at MedX last year. I went into her office with just like a Post-it note with 3 long-term goals that I had. So it was 1, and in order of priority, 1, to get off of 1 more medication, 2, to walk 3 blocks without sitting this time instead of half a block, and then 3, some other long-term type of goal, like I want to be able to pump gas this time, or like simple things like that. And when you come prepared, which I think it's patient's responsibility to also know yourself, like Meredith said, know yourself, come prepared and be assertive, she was able to work with me and incorporate what I wanted to with what she wanted. She was like, okay, you want to get off medication, this is what we can do, we'll work with this, and so and so. You want to walk this long, I would recommend let's set up a physical therapy appointment, and there. And also, I found that communicating with them effectively by comparison. So I'd be like, last time I saw you, I was able to pump all of my gas. This time, I've been a little bit of a flare, so I haven't done that lately. It's been too hard.
Oh, you've got something to add?
Yeah.
Please.
Well, I'm wondering, Rohit, and I guess kind of what you're talking about as well with quality of life goals, because that's what we're talking about here. I have found that part of communication and conversation missing from my care, where it's very much focused on, is your SED rate going down? Is the inflammation in your body going down? It's very clinical value-based and less personal value-based. And for me, my labs can be okay, but I might be really struggling. And I've had a really, really, really hard time opening the door to that communication. There just doesn't seem to be a door open wide enough. Are you taught how to look at the emotional, the socio-cultural impacts and how to communicate that?
When we're taking a patient history, we're taught just don't interrupt the patient. Let them say everything that they need to say. And in the richness of your narrative, we'll pick up all the details that we need to. That comes with practice, but that's how we would pick up those social cues, those emotional cues. Yeah.
So I would be remiss if I didn't mention that I was taught at this meeting 2 years ago by Erin Gilmer, who did that really touching video stream yesterday about asking the patient at the end of the visit, did I get it? Because one of the things that she was complaining about was that she frequently left an office and felt like she and her doc didn't connect, and that her message never got across. And for since this meeting 2 years ago, at the end of my initial visit with every patient, I asked them, did I get it? Did I answer your fears and concerns? And, are you walking out of here feeling like this was a worthwhile meeting for you?
We've got stuff in the audience. Go ahead. Got lots of stuff in the audience. I'll go up there too. All right. It'll be fun.
Hi, this is for Dr. Mark Katz. Why is it your goal to answer all the questions before the patient gives you their information?
Just because I want to be able to anticipate their needs. And I feel that's part of my job, is to understand what the problem is. And a lot of times you can just read from patients' nonverbal cues also, how afraid they are and what's on their mind. So, I don't get it 100% of the time, and many times there are some things in there that they do. But I try to have anticipated a lot of the things before.
And that's like a measure of personal success for you? Or
Yes.
Okay. And then my other question is, and I asked this in the last session that had, both doctors and regulatory, previous FDA panelists, patients, patient advocacy, all that. I have a mother with a chronic illness, and so I just got tired of repeating the patient history because she's so sick she can't do it. So I went to all her doctor's appointments with her, all of her specialists, all of her. I mean, I have a page in here of her treatment plan, which is a bubble chart infographic that I made with a pen and a piece of paper, because I could not figure out how to integrate the different treatment plans from the different specialists. And our PCP doesn't do that. It seems like he should be maybe the center spoke. I mean, the wheel of the spokes, but he's not. And I don't think that that's an expectation of him. So I don't fault him. But I got so tired of repeating her history that I put all of her history, all of her surgical reports, all of her allergies, all of her HIPAA information, everything on a USB drive. And every time we went to the doctor, I said, she's very ill. She's in a lot of chronic pain. For her to recount her patient history, or for me to recount it in front of her, is going to put her in more pain, because it's going to be focusing on her chronic pain. It's going to initiate that RSD, whatever. And here's a USB. And they looked at me like I was crazy. And I am being instructed by the insurance advertisers, be a part of your health, be your own advocate, ask your doctor XYZ. But then when I come to do that, they don't really want that. And I don't understand how to bridge that gap. To me, if someone brought me their history, and even if as a business owner in a small practice, I mean, having 3 people taking written patient histories of a patient who's already been a patient for a long time is not a good business model.
Right. So I would assume that if you're bringing to them at the time of the visit, it's a lot. I mean, physically, they probably couldn't go through it at the time while you're sitting there, or the visit would be done. So obviously, getting the information ahead of time would be helpful. The other thing that we also talked about at this meeting last year, that Katie McCurdy's actual suggestion, was developing a timeline and the simple visual clues about, here's what's gone on, here was a hospitalization for this reason, these major tests, and someone can look at that in a few seconds and just get a rough overall picture, a summary of where things are. And I thought that's been a great suggestion.
All right, to the back.
I just wanted to speak to, my name's Emily Liu. I'm a family medicine resident at San Francisco General Hospital, and I wanted to speak to Emily's concern about the kind of agenda setting issue, because that's definitely something that we face. And like Rohit, I learned in medical school, sit there and listen to the patient. And right now I'm spoiled with a 1-hour appointment because I'm, still in training. But, the way they teach it to us, and sort of part of why that's happening, is because as a doctor, you also have an agenda going in that, you know, you want to cover with the patient. But, you know, what they've taught us is that the patient also has an agenda. And so, you know, the ideal thing is for both of you to sort of discuss, okay, so these are the 3 things I want to cover, and these are maybe the 5 things you want to cover. Let's figure out where these overlap, and let's pick 3 things to cover at this visit. Sometimes that's made explicit, and, you know, we're taught to make that explicit, but sometimes I feel like if that's not made explicit, as a patient, you have the right to make that explicit. Like, I see you want to talk about my SED rate, but I also, you know, would like to talk about my quality of life. And maybe we can schedule another visit to talk about these other things that you're worried about. You know, unfortunately, that does mean you have to come back, but, you know, that's one way that we kind of make that balance of if you only have 15 minutes. The other things that I just wanted to talk about briefly was sort of that issue of the healthcare team that people talked about at the plenary sessions yesterday. That's also another way to get around that 15-minute problem because, for example, I have a lot of patients with diabetes. I don't have time, unfortunately, in 15 minutes to go through nutrition counseling as much as I would love to. So, you know, it's wonderful to have a diabetes educator on the team and sort of do that referral out. And it would be awesome if we had someone who also helped with care coordination and that part that, you know, I'd like to look through every record all the time right there and be able to figure out that analysis super fast. But, you know, the reality is we all need help to make that happen.
I guess where I get stuck, so 2 things. I get stuck with the idea of a care team, and I know that a lot, I'd say the majority of the patients in the rare disease community, and even in the chronic pain community, find that their care tends to be very fragmented. And I think a lot of that is policy-based and it's system-based, not so much due to the doctors. The thought of having a team to treat my rare disease, the arthritis I have, the nerve condition I have, and manage my care is so, I don't even have a word for what that would be because I just can't even grasp it. So I think it's great for people that perhaps those systems are already in place. I know diabetes tends to have, I've seen the programs myself in physicians' offices, but for people with rare diseases, I haven't seen it. Maybe at really large institutions that are very solid, but I have not. I mean, there's a huge disconnect, and it's fragmented. And I don't think we're going to solve that one here today. I think that's a system issue, personally. But the other thing with coming back for a second appointment, I get stuck with physicians where it's all about remission. And for someone with my diseases, the farther away you know, the longer you've been away from remission, the less likely it is that it's going to just happen overnight. And a lot of patients in my circle, we stop focusing on that because what matters to us is, you know, can I come to MedX today and sit on a chair like this? Can I shower? Can I run? Can I go for a walk? Can I enjoy people in my life? And it becomes less about, am I going to be cured in a month or a year? Am I going to fail this treatment? And when we're talking goals, I think sometimes those goals, at least in my experience, my physicians have had well, those are your goals in the context of remission. But for me, those goals are in the context of quality of life. So I don't want to wait until I reach remission to achieve those goals. Let's talk about what we can do to reach them now while I have this disease, because I'm living with it. I coexist with it, and it doesn't leave when I leave the doctor's office. And I don't know personally how to communicate that. When I have tried, it has not been receptive, or either I'm not communicating it well enough, which is possible.
So care teams are not a unicorn. So we have a ventricular assist device program for patients with end-stage heart failure who need heart pumps to get them either through to a heart transplant or as destination therapy. We have a team involving social worker, cardiologist, cardiac surgeon, nurse practitioners, actually a couple of cardiologists. We talk about every patient who's had a device implanted, every patient who's waiting, every patient who's being evaluated every week. So, and I don't think that's rare. I think a lot of programs do. It's maybe it's a smaller group of patients than something, and a more common diagnosis maybe than some of the things that you have. But it is done, and it is possible.
Keep the questions going.
So, as a diabetes provider, I sort of actually want to push on, like, we should beat on the healthcare system. We should beat on the doctors to a certain extent. Like, I don't think it's a 50-50, we're all in this together. Like, patients just need to work harder. Like, I think the system is stacked against them, and I think that, there's so many things involved with taking care of diabetes that are, like, so overwhelming that I really think it's our responsibility to create the systems to facilitate the technology that allows all of us to get this work done more efficiently. And I mean, to a certain extent, when you live in a large scale institution that decides on institutional policies about technology, you are sort of trapped. But I think we need to, I think one, like, this example of what Night Scout has done is a fantastic example of what one, like, creative solutions that we should be leveraging, bringing into the fold instead of ignoring them and saying, oh, that's a really interesting project. That's great for you, right? Like, how do we take that and sort of translate to a larger healthcare population? But two, I don't know, we've had some students, like, just kind of, doing ethnographic work or observing in our clinic. And, one of the things she said to me was like, oh, it's so weird. Like, you give the patients a paper logbook. And, like, like, a couple of years ago, I'd be like, oh, yeah, I mean, that's of course that's what we do, right? But, like, we're setting our patients up for failure because we're not providing them with more tools, with more guidance, with more assistance with the technology, and, like, we're not providing the support to keep them connected, right? So bad doctors.
I don't know where to go with that. Actually, I do know where to go with that, but we don't have enough time for that. So let's keep we're gonna have one question up here, and then if you don't mind, I have a few more things I wanted to. We'll keep it going with you. You have a question? Go ahead.
So two just thoughts come to mind. One is it doesn't feel like there are a lot of tech tools or approaches to synthesize the agenda of the patient and doctor before a visit. Like, what if a doc posted to the the MyChart, here are the questions I'm going to ask you, so you can be thinking about them, and even post your answers, so you could use the visit much more from problem solving. It feels like so much of it is used to relay information, which seems like a really inefficient use of that time. So that's one just question is, do we see tools out there that help do that effectively? The second is, it's interesting. I'm wondering what the value would be for any doc to do at least like a couple of focus groups a year with a group of patients with the condition he or she treats, and just have them talk about what it's like and what their experiences are. Because my guess is if there was a deeper understanding of some of those issues, like, here's what I want to do, it would just naturally come out of the questions. But it doesn't naturally fall, an ethnographic kind of discussion doesn't come out of so I'm just wondering what opportunities there are to have a narrative part of your practice that maybe isn't in the visit, but is some way to relate to your patients separately. So those are two ideas that I just had as you guys were talking.
Can I touch on that a little bit? I think it goes both ways. Like, patient engagement is it's not necessarily new, but it's slowly starting to take hold mainstream. Like, I recently had an appointment, and the office manager or the office assistant actually sent me the documents that I needed to fill out in advance. And slothfully on my part, I didn't fill them out till like the day of, and I scanned them and sent them back maybe an hour or two before my visit. But that would have facilitated, if I had done that in advance, that would have facilitated a better conversation at that particular visit. So I do think that some larger health systems are working towards that methodology, and patients need to be aware of that and do their part as well. So, and send it back, because I think a lot of people, if they get something in the mail, they just kind of wait till the day of and take it in. And as the young lady here in the green print was saying, when you get to the office that day, they don't have time to read all that information that you provided for them. But if they had it in advance, they may have an opportunity to do that.
Keep the questions going. Go ahead.
Okay. So I was wondering, I had an idea.
Let me answer Claudia quickly for a second. So the real answer is to expand Copilot to both of your questions. And Nick's going to talk about that tomorrow or some. So I won't steal your thunder.
Go ahead. Yeah.
Okay. Is there room for a patient advocate who's trained, I'm making this up right now, with maybe a 2-year degree like an LVN is, but a patient advocate degree in a community college who would actually be employed by the hospital or whatever and go to, particularly with chronic illness, and to the office with the patient so that the patient who is sick and is not able to maybe give you all the cues that you need has an advocate who can and can help them keep up. Because I was carrying my mother's notebook around like this, and I just got tired of carrying that and wanted to put it on a USB because my back hurt. So is there a role that doctors in general would respect within the medical community that would be something like a patient advocate?
So I guess it would be how it was implemented. So this you're saying is an independent person that you would hire to come tell the story on your behalf, or your mom's
I
behalf?
just made this up.
Okay.
They actually do exist. I was going to say they do exist. Whether or not it's respected, I would defer to Dr. Katz to answer. But there are programs that do exist, like degree-seeking programs for that.
Where?
I can provide you the information. I want to say it's advoconnection.com,
Okay.
but I can give you some more information. Google Trish Torrey.
Thank you.
Trisha Torrey.
Okay. And yeah, would that position be respected by doctors in that
So
visit?
devil's in the details. So usually I like to hear from the patient themselves what their issues are, and if there's suddenly an intermediary there speaking for them. You know, because sometimes you're asking a husband the question and the answers are always coming from the wife over here. Right? So different issues. So it would depend on the situation and how it was done. If it was somebody who had some baseline medical knowledge and can summarize, a 12-inch chart, sure, that would be great.
Question?
As long as they did it well.
Well, I think all of us respect people as well, but my point is the missing link when I drew this info chart of, okay, there's a neurologist, there's a list, there's a pelvic, there's a urogynecologist and a pelvic reconstruction surgeon and an anatomy specialist, and they don't talk to one another. So what, as a business, coming from a business career of 20 years, I thought, what does this mean? It needs a project manager. Project managers are educated in whatever their project manager.
Right. And in the past, that used to be the primary care doc who would be the central quarterback for everything. You're right.
So what is the solution? Because it is not now. The reality is free whether we believe it or not.
I would say a lot of it also depends on electronic health record interoperability. That's something that the industry is working really hard on right now, so you don't have to carry that binder around to all the doctors you see. So that's another thing to keep in mind.
The term for it is patient navigator. So if you look it up.
Are they navigating?
Yes. They're assisting the patient in navigating the healthcare system, and they can be paid by the private party, by the patient or their family, or they can be hired by a hospital institution. It's a relatively new field, but it's growing, and it definitely does exist now. Yes.
Well, be careful because patient navigator has lots of different definitions at different organizations, so it's not necessarily just this.
Yeah, I'm just thinking out loud of a standardization, like we have standardization in how you get an MD or how you get a JD. So can we standardize a curriculum for a patient advocate, patient navigator, whatever you want to call it, that is then recognized by the industry, supported, and respected?
So I actually have a question leading off of what the woman in the green up there said with the idea of a patient panel or a patient group, a focus group. I love that idea, especially if it were a recurrent thing and not just a once in a blue moon thing, because I think that's very easy to disconnect from. How would the clinicians here or the educators here suggest that patients like myself go about proposing that to their physicians? How do we approach them with that in a way that is accessible and open and receptive? How do we help them be receptive to that? Anyone?
I mean, just bring it up. I mean, one of the reasons I keep coming back to this meeting, it's the only real place I get feedback from patients, right? Patients coming into my office, I guess, are too intimidated to bring it up at that time, and they have too much on their minds. They're facing surgery, or they've just recovered from surgery, and, it may come up later on. But I've gotten emails, letters, things from patients with suggestions. but I probably get more here than I do out of my practice from that standpoint.
From a medical student perspective, I can say that, and we were talking about this earlier, if you're able to plug medical students into patients with rare conditions or chronic conditions that we don't see every day, that'd be invaluable to our education. But you have to do it in a way that doesn't take up too much time, because the first 2 years of medical school are chock full of information, and we are up all night studying this. So adding more into that will, I would think, make us not, we wouldn't give it the amount of respect it deserves. So if we were able to somehow passively integrate that into undergraduate medical education, I think it would be really good.
There are a whole lot of bigger topics that we're, potentially setting out there for future Medicine X conferences. You've been holding on this microphone for the past 10 minutes.
Oh, thank you. I would, I guess, just introduce my comment by firstly saying that this is the first time I've come to this conference. Very enjoyable. And I came for other reasons, but I will identify myself as a cardiac anesthesiologist who also manages a large physician practice group in the Southeast. And my take on this conversation is that as we've evolved for all good reasons away from a system that has become antiquated principally because the downward pressures no longer enable it to exist, there are unintended consequences of our evolution, and I think we're seeing them and hearing them today. I guess my comment is one of the things that we have to appreciate is that though, and I work with the most highly regarded colleagues that I can imagine, and in general, physicians are good people and they want to do good things, and I think it's fair to say that we are not able to do everything perfectly. And I think that expectation needs to be couched with the understanding that though these are all wonderful expectations, they just sometimes may be beyond the means and capacity, not just because we don't want to, because I think it's fair that we do, but we just don't have the means with the production pressures that exist today. And I think the patient has to be sensitive to that as well. And between the two working together, I think there will be better solutions.
There are a lot of nodding heads. There are a lot of questions, and I'm sorry. We have 4 minutes left, I believe, and I wanted to give everybody on the panel, an opportunity to offer a closing thought. If you want to continue the conversation, we have the hashtag, we have face-to-face conversations. I encourage you to take advantage of that. Really quick, though, in this audience, how many people would identify as patients? Would you mind raising your hand? All right, what about medical professionals, doctors, whatever you want to call it? What about students? I figured that right there were students. You guys are a little underage. Okay, I was just curious because, there's a lot of opportunity, even if we're only talking for 45 minutes or whatever, but just wanted to see what we were dealing with here. All right, so we've got 3 minutes left. We've been talking about a whole range of things, but as far as, I suppose, the 15-minute meeting is concerned, I heard a lot of come prepared and be thorough on both sides. Anything else you want to add to that, or just say goodbye or whatever? I don't know. We'll start at the end. Nikki?
Oh yeah, I just wanted to add on to everything. I agree with what you guys are saying. It's both responsibility of both parties. For the patient, come prepared, be assertive. If you only have that 10 seconds where they're asking you, how do you feel? Give everything you've got to give. And as for the doctor, it's not about, I don't think it's necessarily about like, we need this massive systematic change, which, we do. But for me, it's small things. Eye contact. I understand we're pressed on time, but please don't cut me off when you just asked me the question type of thing. And it's just really small things just like that. Eye contact, greater communication. My doctor is great about emailing. If you're not, then let's establish another way to do something like that.
Nikki stole the words right out of my mouth. So I'll just echo what she said.
Sure. I think if you don't get your questions answered in whatever your visit is, then there's nothing wrong with a follow-up letter or email.
And I think to piggyback off of that, as best you can, try to contact the office in advance and see if you can fax or email or send in your questions, or if you have medical documents that they're requesting, send those in advance of your visit.
Yeah, Nikki, I think you you stole the closing there.
One little thing that
But I will say thank you for that reminder about expectations of patients and expectations of providers, because I don't think that was something that we explicitly said, but I think that was something that needed to be explicitly said. So I think both parties could probably step it up. That's my 2 cents.
All right. So our hope was that there's something tangible for each of you to contribute to whatever future doctor interactions you have. Be respectful, be happy at times, I suppose. Have a nice day. Thank you for coming.